Good day, everybody. Good morning, good afternoon, good evening, wherever you are in the world. Welcome to this 3D conversation. My name is Sandro Galea. I serve as Dean, Boston University School of Public Health, and I'm hosting this 3D conversation with Dr. Rana Hajjeh about wearing my hat as chair of the 3D Commission. So briefly, the commission is a commission that was started by Rockefeller Foundation partnership with Boston University around the intersection of data, social determinants, and decision-making. The vision behind the commission was to ask, now that we have a richly developed social determinants of health agenda, how can we think about getting better data to inform that agenda? And how can we make sure that that agenda actually translates into creating better health? We brought together 24 commissioners from all over the world, and the commission deliberated over a 2-year period, and the final report of the commission is going to be released next week in partnership with the UN General Assembly meeting. Now, as anybody who did calendar math realizes, when I said that, the commission was conceived and started before COVID, and it actually ran then entirely through COVID. So needless to say, the COVID moment colored very much what the commission's deliberations were, what the commission was thinking about, and what eventually emerged. But I think centrally, COVID really heightened the salience of what the commission was tackling, because everybody realized all over the world very quickly that the consequences of COVID were very much driven by social and economic conditions, and that social determinants were inextricable from the costs of COVID. So I think the COVID moment, which in many ways revealed what was already there, illustrated the importance of social and economic determinants and how any decisions that are made, be it in a time of pandemic or not, need to take into account people's social and economic circumstances. We saw this all over the world, where people who were socially and economically disadvantaged, people who were minority groups, people who were marginalized, were the ones who were most affected by COVID itself and by the economic consequences of the global COVID recession. And that, to my mind, speaks very strongly to the importance of keeping social and economic forces in mind as we're dealing with health in all dimensions, including and perhaps particularly in a time of pandemic. And what the commission report does, that will be released next week, is it articulates a set of principles and core recommendations for scholars and policymakers for keeping in mind the data that we need to always make sure that we're measuring social determinants to make sure that decisions are made with social determinants in mind. So with that background, I'm now going to turn over the conversation. And the format here is I have the great privilege of asking Dr. Hajjeh questions, and we'll go back and forth. We're happy to take questions from the audience through the Q&A function, and we will incorporate them into our conversation. But first, a word of introduction. Dr. Rana Hajjeh is Director of Program Management at WHO Eastern Mediterranean Regional Office, EMRO. In that capacity, Dr. Hajjeh directs and leads all the technical public health programs at the regional level, including universal health coverage and systems, communicable and non-communicable diseases, information and science, as well as health promotion. Prior to this role, Dr. Hajjeh worked for 23 years with the US CDC. She has considerable experience in health policies and systems and supported development of various global policies for prevention of infectious disease. She's a well-known speaker, advocate for strong public health capacity in the region, and for the right to health of every person. Dr. Hajjeh, it's really a pleasure to have you today. It's an honor to be in conversation with you. Thank you for taking the time. Thank you for joining us.
Yes, thank you very much, Dr. Galea, and good morning to our viewers in the US. Good afternoon to viewers in our region, in the Middle East and in Europe. Very nice to be with you. Thank you for inviting me.
Thank you. Well, Dr. Hajjeh, let's start with a bit of a regional anchor and start with the region that you're in with EMRO. Can you talk a little bit about how you see, starting with social determinants, social economic determinants, how they are shaping the health of populations in your region, and then what the applicability of data is to those determinants and how that should be moving us forward in decision-making?
Yes, sure. I would like to start actually with this report. It's a very big report that we launched in March. It's a commission that it's basically the result of almost 2 years of work. It started right before COVID, which is our report of the Commission on Social Determinants of Health in the Eastern Mediterranean region, in our region. It was actually chaired by Sir Michael Marmot, and we had very good team on the commission from various experts in many areas from the social determinants of health in the region. And the reason we commissioned this this report is because we recognize that social determinants of health are very critical to health in our region and to advancing health in our region. So, of course, you cannot talk about the region like the Eastern Mediterranean. And I would like to take a second to define the Eastern Mediterranean, because people are used to some other terminology like MENA, Middle East and North Africa, or Middle East only. Eastern Mediterranean region, we cover about 22 countries, mostly in the Middle East, but it's most of the Arab countries, in addition to 3 countries that are considered part of South Asia for many of the other UN agencies, which are Pakistan, Afghanistan, and Iran. So that's why we have this name, the Eastern Mediterranean. And our region, of course, is well known, unfortunately, for the many emergencies, the many humanitarian crises. Actually, some of the largest humanitarian crises right now in the world are in our region. Countries like Yemen, countries like Syria, just recently Afghanistan. And of course, these, we do have many inequities when it comes to health services and health systems in the region. But on top of that, all the results of the conflicts for a very long time, the chronic conflicts, the emergencies in the countries have really led to significant weakening of the systems, and to even emphasizing more many of these social determinants of health, or these inequities that come from different distributions of these various determinants of health in the region. So for us, this has been really critical. We recognize, of course, that without data, it's very hard for us to move ahead with very specific interventions, which is why we launched the report. And as I mentioned, again, I mean, this is it's a very big report. The executive summary alone is about 60 pages. But it's a very detailed report about the current status of the SDHs, if I can refer to them for short, and also comes with very strong recommendations for what are some of the key actions that need to be taken in order to mitigate the inequities that are resulting from these how these determinants have impacted access to health in our region. We have been focusing on universal health coverage and the right of every single person in the region to have access to quality health services. And also we have been advocating, in addition to the health for all, for the importance of many sectors and many partners to be involved. Our actual motto now in the region is health for all by all, because we recognize that the health sector alone cannot deal with all the issues that are relevant to the determinants of health. And we also recognize that many of the determinants of health fall actually under the development side rather than the health side, which is why it's very important to engage the various other sectors in ensuring everyone has access to adequate health services.
Well, it so turns out that our last 3D conversation was with Sir Michael Marmot, actually, and he referred to the EMROR social determinants report. Yes, and he told the story about how it came about. Can you lead us through one illustration from the report about any particular dimension of social determinants that really struck you, that lends itself to a better understanding through data?
Yeah, I mean, there are many examples, really. I mean, some of the key issues that we are also grappling with now, for example, with the COVID-19 response, for example, access to vaccines. In many of our countries, access to vaccine is difficult in certain areas, where, like, we have, for example, what we call our Gavi eligible countries are the countries, the countries that have, more, our developing countries, I usually like to say, or limited resources. And these are countries that have benefited recently from Gavi support, but these are countries that have really limited resources because of lack of funding. That often, we have programs that have suffered, and we have kids who cannot access vaccines in certain areas. We have, our region is the only region in the world that continues to be endemic for polio. We have two countries, Afghanistan and Pakistan, are currently the only two countries in the region where wild polio virus is still endemic. And in these two countries, it is often an issue of access. It's an issue of access in certain areas that are very difficult to access, partly sometimes because of security, but sometimes partly because they don't have the developmental infrastructure that is really needed to have adequate access so that the vaccination campaigns can reach them, for example. I mean, that's a very straightforward example. We have examples where women from some few of the countries where women could not reach the services they need for basic reproductive health issues because they don't always have easy access or mobility to go to health centers. This is one of the areas. I mean, we have a couple of countries in the region, even though there was quite a bit, for example, in Afghanistan, quite a bit of advances were done even previously with the, before the SDGs, when we were still dealing with the Millennium Developmental Goals, countries like Afghanistan made major progress in terms of maternal mortality, for example, but they remain one of the highest countries in our region in terms of maternal mortality because of the issues that are relevant to women access to health services in particular.
When I look at your career, you've had an amazing career in public health. It seems like you've been involved in all sorts of difficult challenges. You haven't chosen easy problems to tackle. And I can imagine that for many of those, you did not have the data that you needed to properly characterize the problem. Can you just lead us through how you've thought about problems for which there is no easy data in the past, and how you've gone about advocating for data, and how you have pushed to better characterize the problem to the end of finding policy-driven solutions?
Yes, sure. I mean, maybe one, there are really many examples. Some of them were from a completely unexpected situation. Like, for example, when I found myself almost now 20 years ago dealing with the issue of anthrax attacks on Capitol Hill, where we were asked to go because there was an exposure to anthrax, and then we had many employees in the Capitol who were exposed, and we didn't really know what to do for them. And that was a situation that really was very difficult. At the time, we realized that research on anthrax, for example, in the US has stopped many years ago, and we had to make a decision on how to protect many of these workers who were exposed. And what we did is basically we looked at all the literature available, whether it was relevant or not, and we tried to extrapolate based on that by discussing with various experts, digging more into the data, and try to come up with, even sometimes referring to other studies like animal studies. We had situations where we didn't even know how to address, for example, prevention for humans, and we had to rely on some studies at the time that were done among animals. Maybe one of the most illustrative examples I can use is my work with the Hib vaccine initiative, which was a Gavi initiative. Gavi is the Global Alliance for Vaccine and Immunization, and back in 2003, 2005 actually, sorry, I was asked to direct this new initiative that Gavi was co-sponsoring. It was a consortium of organization between WHO, CDC, Hopkins, and the London School. And the main goal of the initiative was to support Hib vaccine introduction in developing countries. And one of the main reasons from our initial assessment that was behind the delay in introducing these vaccines is that many of these countries were not convinced that Hib or Haemophilus influenza was actually of significant burden in their countries. And we all know now, 20 years later, we all know that Haemophilus influenza is one of the major causes of both meningitis and pneumonia in children all over the world, not just in the US, but at the time, back in 2005, most of the data had come from countries like the US and Europe, and there was really very limited data from countries like, in particular, in the countries that were Gavi eligible. Most of them was the largest bulk was in Africa, but many countries also in Southeast Asia and the Middle East. And what we did is, after doing a quick assessment, because we didn't have a lot of time, we had 4 years for the whole project, but we started having very focused missions to the countries, prioritizing certain countries, of course, with the larger populations or with the highest child mortality, because we knew that pneumonia, for example, was one of the most important causes of mortality. Pneumonia and diarrhea were the two most common causes of mortality among children. We started really reviewing all not just the peer-reviewed literature, but when we did these focused missions to countries, we would look at some sources of data that are not always easily available in the peer-reviewed literature. For example, in many countries, we found that you could find a lot of data that is somewhat hidden, what I would call the hidden data, data that is available in academic institutions but was never published, data that you can get on child mortality or from, let's say, verbal autopsies or whatever, from ministries of health, etc. And we, almost in every single country we went to, we found that there was quite a bit of data. And when these data were actually collated and presented to policymakers, it was very convincing, and often that's all what we needed really to support the decision making. So decision makers want local data. If I'm a policymaker in Egypt and I have to make a decision regarding introducing vaccines that are going to cost me millions of dollars per year, I really need local data to convince my Minister of Finance, for example, to fund this vaccine. And that's what we did. So basically, after doing our initial work, we came up with a strategy for Hib vaccine introduction that relied on three major pillars, I would call them. The first one was communications and advocacy, because sometimes it's not just data, but you really need to be clear about the messages and have them as much as possible supported by the right evidence. The second one was about research, because we recognized that there are certain gaps in data. For example, some countries told us, forget it, we're not going to introduce the vaccine until we have the local data. So we needed to support a variety of research studies. Some of them had to be done in the short term in order to generate the evidence. And then the third one was about coordination. So, and the result of the HIP was that the vaccine was introduced in all the 72 Gavi eligible countries. When we started, there was only 19 countries out of 75 at the time, because this depends on the eligibility criteria for Gavi funding. 19 out of 75 had HIP vaccine, had made the decision to introduce the vaccine. By the end of the 4 years, we had all the countries, all the 72 countries that were still Gavi eligible introducing it, and also many other countries, middle income countries that basically were driven by the momentum, and they saw all the data and also made decisions. So that's probably one of the strongest examples I can use in terms of using data to guide evidence-based policy decisions.
That's really interesting. One of the things that emerged as you were giving that answer is something which I've written a little bit about, and it always comes up to me when we're thinking about social determinants and measuring them, is balancing the urgent with the more long-term important. And you're dealing with a region you mentioned earlier about some of the countries that are in the region where there's a lot of urgent need. And I'm just wondering what your reflections are on that. I was wondering what your reflections are on for anyone who's interested in generating health over generations, and how do we balance that? How do we balance the urgent with the important, and how do we bring to bear data on both to make sure we don't lose sight of one over the other? And of course, in a time of COVID, that's been even more heightened as an issue.
Yes, of course. I mean, this is something we deal with every single day. You know, there are decisions that we have to make on certain intervention, on allocating resources, for example, where we don't always have all the data we need. Of course, during COVID, this was a huge issue in our region, all over the world. But also, for example, during Ebola, I spent quite a bit of time when I was at CDC, partly because I'm Francophone, but I spent a bit of time in West Africa dealing and supporting countries to do the Ebola response. And of course, when you are in the middle of such an emergency with so much pressure from the public, from all over the world, they don't. We don't always have the luxury of time to collect all the quality data we need. So we make the best decision we can based on the data we have. And sometimes the data is limited and it's going to need, we rely on expert opinion. We rely sometimes on extrapolating from similar situation. You may not have data from Ebola, but you may have data from other similar, let's say, viral hemorrhagic fevers, etc. Similarly, when we were dealing with the COVID-19, as you know, especially early in the pandemic, we were doing a lot of maybe comparisons with other coronaviruses, for example, with SARS, with MERS, the Middle East Respiratory Syndrome, which was another one. Our region had a lot of experience with MERS, especially in the Gulf countries where the Middle East Respiratory Syndrome was focused. And so we made decisions based on that. But then we tried to respond to the urgent needs. The urgent needs, for example, would be to make sure the healthcare needs are met. Countries were dealing with lack of PPE, the personal protective equipments. We were dealing with lack of oxygen or ICU care in many of our countries, and these are matters of life or death. I mean, we cannot send healthcare workers to take care of COVID patients without protecting them. We needed to ensure oxygen is available in all these countries. So we had to mobilize a lot of resources, etc. But so we were going through a very strict prioritization exercise almost on a daily basis. At the country level, of course, working with we have country offices and they work very closely with ministries of health, but also here at the regional offices, we were trying to decide. We had the limited amount of PPE, for example, and how do you distribute them to the various countries? For some countries, where, for example, infection control programs were very weak, we had to conduct urgent training to support. A lot of time we couldn't even travel early in the pandemic, so we were doing a lot of online training. So basically, I think you really need to contextualize it to the countries and try to almost put yourself sometimes in the shoes of people who are making the decisions at the country level and what are the other needs they have, but also, you need to keep in mind that there are things sometimes that they are not thinking about in the heat of the moment that we have to also keep in mind. For example, for many of our countries, very soon after the pandemic started, we realized that people have forgotten about some essential health services that needed to be maintained. There are pregnant women who need to go and make sure they get their services. There are kids, who need their shots. They need their vaccines, and the pandemic pressure was so huge that countries for a short while they actually forgot about that, and we conducted so a group like WHO, maybe we had the luxury a little bit to detach slightly and to conduct a survey. We actually conducted a survey very soon, early in the pandemic. We conducted a survey with all our countries looking at continuity of essential services, and we demonstrated that most of them have dropped significantly, visits to healthcare centers. And we took the results of the surveys and we showed them to the policymakers, and that was really helpful because they did not really realize that there was already such an impact on health services, and this led to a whole approach or a strategy to strengthen or to ensure continuity of health services. We came up with guidance from WHO back in May of 2020, actually, when this first came up, to guide the continuity of essential health services in countries in spite of the pressure of the pandemic and all the additional needs that came with it.
This is really super interesting. Can you comment on a bit of a detour, if I may, but when we talk about social determinants, I often feel like there is one social determinant that trumps everything else, which is war and conflict and trauma, just, it upends everything. And in your region, there are a number of countries that are actually going through large-scale trauma. And it so happens that in my own scholarship, I've actually done quite a bit of work about the consequences of trauma. So I find myself particularly interested in that. Can you just comment a little bit about, large-scale conflict and how that reshapes the entire social and economic environment, and how that then becomes health, not just in the present, but across generations? And I suppose I'm asking you to comment on that, but also looking to how a better understanding of those needs can lead to mitigation of some of the consequences. It's a huge question. We could talk several hours just on this question, but I really would love learning from your thoughts on this.
Yeah, I mean, as you mentioned, thank you, Dr. Sandro, but I think it's really, I have personal experience. I grew up in Lebanon in the middle of the civil war, and when you are in a war, your priorities are very different. My priority was to find a safe shelter, to find water, to find electricity, to have food. We often struggled to ensure that we didn't know if every day there was bread or not. So the priorities shift significantly during wars, and the basic human needs: safety, food, shelter, water. These are really what people are worried about. They're not worried about whether my child is going to get their vaccines or not. They're really some basic needs, and that's exactly what happened in our countries. Of course, it gets even worse. You can afford probably to miss on a child vaccination for a couple of weeks, but then when we get into the chronic conflicts, many of the countries in our region have been in conflict for like 10 years, 20 years. Some of them are getting close to 20 years. After a while, war becomes part of your everyday routine, and you have to start paying attention to some systems issues. How are you going to maintain health? As I keep one of my favorite books is Love in the Time of Cholera. So I keep saying that, you have to maintain health in the middle of war. So just because we have a war, it doesn't mean we stop paying attention to basic health services. And I think, in our countries, and WHO role in some of these countries that have been experiencing wars for a long time, WHO role has shifted significantly, because it's not just about the normative guidance that we used to have, supporting with technical guidance. In some places, WHO's role shifted to actually managing trauma centers or war hospitals, or setting up even field hospitals to take care of some of these issues. So I think it's really, it changes. War changes your whole perspective, because of course also the resources that are available that come sometimes, especially now, a lot of resources go to support humanitarian needs. And this often does not lead to building systems over time, because you are dealing with very acute issues rather than building systems, specifically among refugees and migrants. And our region, even though we're only about, in the global context, we have only about less than 10% of the global population. Our population is a little bit less than 700 million, but we actually have in our region almost 2/3 of the world refugees. About 64% of the world refugees actually are in our region, and these people are living often. Many of them are living in camps, but we have also some countries in the region where refugees are living in the middle of the population, and they get very different types of access to some of the health services they need. So addressing the population, the needs of some of these very vulnerable populations. They're vulnerable for many reasons. They're vulnerable because of their socioeconomic situation. They're vulnerable because they're not living in stable environments. They're vulnerable because they're somewhat living in fear of losing even the little stuff they have, or leaving the country, their hosting country any minute. So these need very strong coordination across many partners. My really approach also to social determinants of health is that this is not just a health issue, of course. This is a development issue. We cannot address the social determinants of health only in the health sector. This is a multi-sectoral approach, and it's everybody's responsibility. It's a global responsibility, but it's the responsibility of many partners, including health partners, development partners, civil societies, governments, donors. And if we don't follow a multi-sectoral approaches to the social determinants of health, we're never going to be able to really deal with them and mitigate their impact on health, especially in countries that are in war and conflict. And maybe to end, I don't know if I answered your question exactly, but to end, I want to mention one of the initiatives that our region recently sponsored is an initiative called Health as a Bridge for Peace. And we, this is, it sounds really political, but we wanted to really use health, if you may say, to encourage peace, or at least some peaceful times that allow delivery of health services. We used it some in Yemen, for example, because in Yemen we established what we call the humanitarian bridge, where many countries are supporting flying over humanitarian needs to Yemen, and even negotiating with the various conflicting parties on and off, so that sometimes war can be stopped in certain areas, for example, to allow entry of immunization teams to go and do polio vaccine campaigns, for example. We have had many countries in our region where we negotiated with the opposing parties to beg them basically to stop the conflict for a few days, so that we can go in, do the vaccination campaigns, and deliver any other services that are needed. It's not a long-term solution, but at least it allowed us to deliver some of these critically needed services.
There's a question actually in the Q&A which builds nicely on this, actually, I think, which is, how does one better make the case for the overlap between need for equity and stability and health in the long term, particularly when there are so many pressing short-term needs?
Yes, I mean, it's a very good question. It's actually, I think you kind of have to look at it from the country's perspective. I mean, equity is critical because it affects everyone. I mean, now we're using a very, I think it's becoming a bit of a maybe slogan, but when we say no one is safe until everyone is safe, for example, during the COVID pandemic. This is probably one of the easiest examples because everyone now can see, like, until you vaccinate the majority of the world, the virus is going to continue to circulate. And if the virus is continuing to circulate in one country, then now with all the travel, with how easy pathogens and viruses can travel across countries, this can spread, it can mutate, we can have new variants, and it will affect everyone. This is at the global level, across countries. So if the whole world, which is, we are facing a major inequity in vaccine distribution. And unfortunately, despite our best efforts, despite our efforts and coordination efforts with all countries to ensure that vaccines get distributed equitably among countries, we ended up with a situation where the richest countries were able to vaccinate something at least over 50% of their countries, while some countries, the poorer countries, have less than 5% or 2% of their population vaccinated. But this is not just a slogan. This is if the vaccines are not now distributed in an equitable way to everyone, regardless of their socioeconomic status, then the whole world is going to remain in danger because the virus is going to continue to circulate, and then this will affect everyone. So I think we need to, as much as possible, be more convincing with our statements. So of course, from a human rights perspective, from any basic, common sense perspective, equity, of course, makes a lot of sense. But also when you talk to decision makers or political decision makers who are under a lot of pressures, you need to provide to them convincing evidence. You need to make sure they fully understand that this is beyond the slogan, that you have data to support the argument that you are making, for pushing for equity in distribution of health services.
Yeah, no, it's really interesting, right? And this balance between the two is really, I think, fascinating. Can you let me just ask you a little bit about try to take that balance and now ask about national and regional policy. So from your experience, particularly in the Emerald region, can you talk a bit about the balance between sort of regional, local policies and then national policies, and the intersection of the two, sometimes in conflict, sometimes in complement, and how one pushes forward with a agenda to make sure that social determinants are recognized, recognizing that there's often this tension about which level of government is responsible in helping?
Yes, we usually, for the region, even though we have quite a bit of diversity within our regions, we have regions that we have some of the richest countries in the world, and we have some of the poorest countries in the world. So we always try to take into account the context of our region when we are developing these, regional policies, and to make sure that we're not having kind of like a one size fits all policy. But in general, I'm trying to think about some recent regional policy that we passed. I mean, even if we look at our, push for universal health coverage, which is one of our biggest, really, this is our ultimate goal. By having universal health coverage is really the illustration of equity, that everyone should have access to the not basic, to the not even just essential, to all the health services they need, and they need these services to be at quality level. So for universal health coverage, we had a couple of years ago, we had all our countries signing our Salala, what we call Salala Declaration. It was a Salala in Oman, where we had a meeting on the occasion of Universal Health Coverage Day in December, and we had developed a compact for universal health coverage, and all of our countries' ministers were attending, and they all signed off on that compact, basically acknowledging that it's their responsibility to implement the universal health coverage. However, nonetheless, I mean, even now, 2 or 3 years later, we still faced with a situation where we have a huge spectrum of UHC service coverage, or what we call, the service coverage index, with countries almost up to 90%, and we have countries that have still very low service coverage index, and still we have a lot of people paying out of pocket, etc. So we we try to learn also from the examples, because you don't have to be the richest countries to have, for example, very good universal health coverage. We have countries that are, middle income countries that have implemented, that had the right political commitment. It's really what we have found is that, and even during the pandemic, this was highlighted further, one of the most defining factors in terms of success is leadership and governance, and strong governance in countries in terms of ensuring the implementation of the health policies and health strategies. So without that leadership and governance, it's very difficult to really push the the implementation of policies. And so we have been working very closely with our countries. Once we have this regional guidance, we help them develop their equivalent national policies, because we see our support as kind of a bit more at a higher level, and then we try to work with countries to customize this regional guidance to fit their own health and socioeconomic and other determinants context. And then we try to support them with the implementation, because often countries, it's not always just an issue of resources. Often it's an issue of having the right skilled workforce. It's an issue of significant difference within the country, because as you mentioned, there are differences at subnational levels. Within the same countries, you're going to find a huge difference sometimes from one area to another. And we do that by working very closely, by assimilating the country context, and by working with countries to develop national, not only strategy, but national implementation or work plans to guide the implementation, but also to bring together to the table all the various key stakeholders who are needed to implement these policies. Maybe I can use an example from recently. Sorry, go ahead.
No, I said please, yeah, go ahead. Actually, I'd love to hear this.
I can use an example recently from Sudan, where the current minister asked us to go to the country to really help, not just to look at one specific policy, but to help to help him reimagine how the health sector should look like in the new Sudan. So that is a much more comprehensive look at the health sector in Sudan, taking into account their challenges, the local challenges. Sudan has many determinants, key issues with many determinants of health, social, economic, geographic, environmental, others that really affect how health is delivered and accessed in Sudan. And what we did is we basically worked with, not just only with the Ministry of Health, but we worked with various other sectors. We worked with all the partners who are there on the ground, and came up with really an approach, a vision for how they should restructure their current and basically redefine their governance of health in order to be able to deliver more equitable health services to all the people.
That's really interesting. Let me ask, perhaps turn it to a little bit more of a personal lens now about you and your work. We often, these conversations are viewed and will be viewed by students and trainees. I was wondering if you can actually talk a little bit about your journey and about the stories that brought you to the work that you do, and that over your career you felt have been most formative for you.
Yes, that's thank you. This is almost really. I didn't think when I was a medical student that I will actually end up in a career in public health. Like many people, I actually find now some of our younger colleagues have probably benefited from more guidance throughout their journey, and they start leading careers in public health really early in life, which is which is really nice. Now, I trained, as I mentioned, as an internal medicine and then infectious disease. And, one of the things I was, at the time I was at Emory University in Atlanta, and we had a very large indigent hospital in Atlanta. And I kept, there were many patients, as I'm sure many people probably would recall similar experiences. There were patients who we get to know by name. They were frequent visitors. You discharge them, and then they come back this next week. And then I really realized that many of these patients, for example, with COPD or others, like these patients would have been much better off if they had benefited early on in their life from prevention services, and they really would have avoided even getting to that stage. So I kind of like gradually started seeing that what we are doing, with all my respect to the great efforts that are done, of course, by clinicians, but we are often treating again and again the same condition that could have been easily preventable if the society has put enough attention on prevention to start with, and that's how I started getting more and more interested in the value of prevention and in public health, with its focus especially on prevention aspects of health. I'm also, I'm a big believer in the role of the community and engaging the communities in making decisions about health, and that's another reason why I also wanted to get into public health, because I knew that public health would not just address individual, health of individuals, but also would look at the health of populations and communities and put it in the context of the many other factors that affect that, especially in particular things like the social determinants, but also environmental factors and many policy issues, etc. The reason and then once you start getting engaged in public health, you get deeper and deeper. There's no return. I know very few people who started on a career in public health and then they said, no, that's not the way for me to go. For the region in particular, what got me here to the region is actually one. I've always been interested in coming back to the region, but there was one specific incident where I was at a meeting in the US. I was giving a lecture on antimicrobial resistance at the time, and then after the lecture, I was approached by was a big guy, actually, a physician, who had questions, and he said, "Yeah, doctor, can I talk to you about issues related to my country?" He was from Iraq. And then I sat with him to discuss issues related to antimicrobial resistance. And then as he was telling me about the resistance problems they are facing in his own hospitals, he started crying. And he actually, he said, we don't even have access to the basic things. I cannot even order a basic culture, but I know that this patient is dying from a resistant infection. Anyway, it was a long story, but to me, to see this really, this physician collapsing, and it really brought it, maybe for me, it brought it very, very close to home. And I realized that, there's a lot, especially many of us who have, had careers in the US, and thought, we would probably be settled there for the long time. I realized that I needed to come back to the region, and I needed to see how some of this experience that I have gained over the years, addressing public health problems, dealing with, developing prevention or other policies, how this kind of experience can be very helpful to build capacity in the region, and how to address health problems in the region.
It's really interesting to hear that path. Of course, I was also a physician who spent my career in public health. Can you talk about key moments in the field when you thought the importance of social determinants really emerged for us, where we recognized that there is no health without sort of social and economic well-being? Like, what were key moments in the past 20 years in your career that you thought it really helped elevate that in the field?
Maybe I can mention a couple of quick examples. As I mentioned again, one of the, there are lots of examples, but maybe some of the striking ones, like for example, during the Ebola crisis in West Africa, when we were trying to convince people that they shouldn't be burying the dead. And, we were in countries where this ritual was extremely important, not just from a religious perspective or whatever, but it's a closure that, families needed. And there was a whole ritual around it. And the way we had approached it initially as a global health community, who was, of course, very worried about the spread of Ebola to these families, but we completely disregarded the importance of the cultural background to these families. Many of them were willing, they knew the risk. These people were not stupid. I'm sorry if I can use this term. They knew that they were at risk of getting infected, but for them, it was very critical to bury the dead and to do what they thought was part of their duties, to give them like a decent burial, etc. And we should, if we really understood this better from the beginning, we could have avoided many preventable outbreaks. At the time during Ebola, we ended up with many families, unfortunately, contracting Ebola because they were doing a lot of burials, at night, or when the authorities were not watching. So I think that cultural depth and understanding would have been really critical to possibly really curtailing the spread of the disease in many countries. But we assumed people didn't know, and we kind of pushed certain measures without fully getting the actual buy-in from the community and the more systematic approach to dealing with this area of social, social determinants of health. Similarly with the COVID pandemic, we were dealing with the same issues, trying to also push certain measures, like the social, the masks, what we call social distancing, even some of the words we were using before. And of course, this changed with time. I think with the COVID, we had learned quickly that these issues can be important. And we started using, instead of calling it social distancing, we started using different terminology, because social distancing meaning almost like separating families or whatever, and, started using things like social measures, public health interventions, other softer language. In certain cultures, and especially in our countries here in the region, and we saw it in many countries in Europe, in Italy and Spain, where you have, the elderly family members living very closely within the same home, etc., telling people that you cannot, you cannot hug your grandmother or whatever. So I think, I'm talking here mostly about the cultural, impact, but also, we dealt with it, for example, with the polio. I used the polio example earlier. With the polio immunization, there was at one point this rumor that the vaccines were being forced on the populations because someone was going to these homes and repeatedly just wanting to give them that one drop of polio vaccine without really addressing any of their other issues. Many of these families did not even have clean water on a regular basis. They did not have access to school. They did not have access to other either health services or other basic services. And the only thing we were going to tell them, and also on the other hand, they saw these people who sometimes looked foreign to them coming to give them only this one vaccine. So we we had a initiative a few years back working with religious leaders, and that was one of the ways we dealt with it, for example, in countries in Pakistan and Afghanistan, where the religious leaders in the communities were the ones who were actually working with us to convince the population using arguments that were culturally, religiously, socially acceptable to them, to convince them that these vaccinations are going to be good for them, for their kids, for the community at large, etc. But so these are, and I can list many such examples where a better understanding of social determinants of health really lead to better health services overall.
That's a wonderful answer. I actually have so many more questions, but I'm going to stop. I'm going to ask you one last one, looking at the time. Can you just, in the last minute remaining, tell us what gives you hope?
Every single day I have something that gives me hope. It's really, for me, what gives me hope is working with people at the country level. Especially when I go to the field and I see people trying to solve their problems with local solutions, with the few resources they have, their commitment to their families, to their countries. That's really, I think, for me, very empowering and energizing. But also, what I see even in the middle of the pandemic, the way the whole world has really pitched in, and the way we research developed. I mean, we were just discussing this morning with some colleagues. We have never had so many studies in our region. We were struggling to get them to do certain studies. But the pandemic really, I mean, in the middle of this misery of the pandemic and this terrible virus and all its impact on our lives and societies, there are lots of there was lots of good things that happened. How people pulled together. I mean, I would love for countries to pull together more and make sure vaccines are available to all our poor countries. But the way that we quickly developed research, the way that we have quickly gotten help from so many countries to deliver services to countries. So that's, to me, that global collaboration in many instances was really energizing, and I hope it will continue. The vaccines right now are our best intervention to stop this pandemic. We know that the social measures alone don't work. So I really hope that we will all pull together to do that. And if I can add, Dr. Galea, I mean, I really liked your 3D because I think, the data, you have the social determinants of health, and then the decision making. These are great. We were using 3D for data, dialogue, and also actually decision making. So maybe dialogue is one is very important.
4D.
Well, actually, I have a fifth one that I think is the most important. If I can end with this, it's about doing.
Oh.
It's about doing. For over now 10 years, we have been talking about social determinants of health. We know what's wrong. We know what the social determinants of health is. We know we have many solutions to address the social determinants of health. Maybe, I went a little bit probably all over the place with my answers, but what we need is more implementation. What we need is commitment to doing. So taking the 3D and adding at least 1/4 D, which is doing and implementation of the solutions that we know will address. And the solutions, as I mentioned, are not all in the health sector. The solutions are often developmental, the poverty, the issues relevant to women's rights, the issues relevant to equity. So I would really, that's my plea, because I think this is a great initiative, and my plea to you at the Rockefeller Foundation, BU Commission, is to help us really moving together to implementation of many of the recommendations from our wonderful report from SDH to help countries really use the data or generate more data for decision making, but more importantly is to really implement a lot of the very well-known interventions that we know will improve health for everybody.
Dr. Hajjeh, thank you so much for a really interesting conversation, really interesting answers, and thank you for ending on hope. It really actually does. You've done remarkable things, and reflecting on your lens on hope, even as you're dealing with some real challenges in the region, is wonderful. Thank you for everything you do, and thank you for being a part of this. Really appreciate it.
Thank you very much.
Everybody, thank you for joining us. Tomorrow we have another conversation with Professor Sundari Ravindran at